of our journal club, a cornerstone event within our esteemed medical research community. Today's session will be conducted in a dynamic question and answer format. Your active participation is not only encouraged, but eagerly awaited. We will be delving into the insightful study titled Improving Balance with Wobble Board Exercises in Stroke Patients, a single-blind randomized clinical trial, authored by Yasith Mathangasinghe, Dr. Yasith Mathangasinghe, and Dr. DJ Anthony. However, the true essence of today's session lies in your participation. It's not just about absorbing information, but also sharing your perspectives, asking questions, and contributing to a vibrant exchange of ideas. So, let's make the most of this opportunity. Let's collectively explore, analyze, and uncover the insights within the article. Moving on to our resource person, it is my honor to introduce Dr. Yasith Mathangasinghe, who is an alumna of our very own faculty. He is a lecturer at the Department of Anatomy, Genetics, and Biomedical Informatics, Faculty of Medicine, as well as a doctoral research fellow in the Australian Regenerative Medicine Institute in Monash University. Dr. Yasith has a robust portfolio of over 50 peer-reviewed publications, and he is also a reviewer for over 30 distinguished international journals. Dr. Yasith's research interests transfers neuroscience, cell biology, and applied anatomy. He is also currently the Assistant Director at the Sri Lankan Journal of Surgery. His work has garnered acclaim, including Best Paper Awards at numerous esteemed conferences and symposiums, notably the Proteostasis and Disease Symposium in Wollongong in 2022, the President's Award for Scientific Research, and many more. In 2020, his outstanding mentorship skills was acknowledged by the students with an award in excellence in student mentoring. Sir, your presence here today is a true honor for us. We deeply appreciate your willingness to share your expertise and insights. We thank you sincerely for gracing us with your participation, especially from such a long distance. With that, I invite our very own Asala Kumarasinghe from the A-Level 2019 batch to lead us through the upcoming sessions. Asala, over to you.
Right, thank you, Abhilasha. So, good evening, everybody, and welcome once again to the Journal Club 6, hosted by the Medical Faculty Research Community. So, thank you, everyone, for joining with us this evening, and a very special thank you to Dr. Yasith Mathangasinghe, who is, as Abhilasha mentioned, a co-author of the research article that we'll be reviewing today. So the title of the research article today is Improving Balance with Wobble Board Exercises in Stroke Patients, a single-blind randomized clinical trial. So before we go and discuss about this research, let's take a minute to remind ourselves the reason behind having a journal club. So we know that, so we are all medical undergraduates. In the medical field, when medicine is ideally practiced, everything is within the scope of research. Nothing is without it. So after all, it is a better statement to say, rather than saying we practice medicine, it is better to say that we practice evidence-based medicine, right? So most, if not all, of the treatment regimens and the interventions that we provide to our patients have some evidence base in the literature. So may it be like a proven efficacy, or maybe reduced adverse effects, better, lower morbidity or mortality in the long term, and so on. So in that sense, we as undergraduates, I think we are better off if we are exposed to more of this ever-evolving medical literature at the undergraduate stage itself. And also in a journal club, when we critically review a research article, we develop our critical appraisal skills, and the insights that we get from that, if we can apply it to our research that we will do in the future, then I think we'll have better researches being done, which will ultimately benefit the patients that we are treating. So with that in mind, let's begin. So I think most of the audience today are less familiar with the specific physiotherapy exercises that are used in stroke patients. So we know that stroke patients do get hemiplegia, and physiotherapy is a cornerstone of helping them to regain their function. So these wobble board exercises, we may not be familiar with what it means. So to help familiarize us with the concept of wobble board exercises, we have a student with us here today. I would like to hand over to Hanshani to explain to us what is meant by wobble board exercises.
Okay, thank you, Ismail. So before going into wobble board exercises, we have to know what wobble board is. In this slide, according to this slide, wobble board is a cost-effective, simple instrument with an unstable surface. So basically, we use wobble board to improve balance, proprioception, and postural control. In our clinical settings, various kind of patients can be treated using wobble board. Stroke is one of them. And when it comes to balance is a complex motor skill. So previous researchers have proved that both static and dynamic balance can be improved using this wobble board. As you can see in this picture, wobble board, in previous slide, supplies us unstable surface. So it helps to train both muscular and neurological systems. Right, next slide, please. In this slide, you can see some kind of exercises that we can use in our treatment regimes to improve balance and all. It's like if we have a patient with stroke, postural balance is one of the main things which is affected by the stroke. So as a result of that, recurrent falls can happen. So because of that, as a physiotherapy intervention, we use wobble board in our settings to improve both dynamic and static and dynamic balance of our stroke patients. Next slide. So when we are doing that kind of balance training programs, we need some tests to assess whether there's an improvement with our treatment plan. So that's why we need these kind of tests. So in this research, the two main balance tests have been used to assess the balance. So those are Berg balance scale and post-pair step test. So as you can see in this slide, in Berg balance scale, we can assess both static and dynamic balance, and it consists of 14 items. So we have to ask the patient to perform them, and then we have to observe them. According to their performance, we have to score them, and at the end we take a total. According to that total value, we can have an idea about their balance. Next slide. Next slide, please. So in post-grad step test, as you can see in this picture, we have to ask a patient to follow the sequence. So patient has to reach each and every square without touching the cane, and as fast as they can. So we have to measure the time that they are taking to complete the test. According to the time, we can have an idea about their balance. So that's all. Actually, this is very brief explanation. I think you got something about rough idea. Thank you.
All right. Thank you, Anshani. So
Thank you.
Now I would like to hand over the floor to the co-author and our resource person today, Dr. Yasith Mathangasinghe, who will be explaining us sort of an overview of his research. Over to you, sir.
Thank you for that introduction, Abhilash and Asela. Can you hear me?
Yes.
Yeah. Okay, cool. Thanks, and thank you for that wonderful presentation, Hansini. If I can share my screen, host has disabled participant screen sharing. Is there any way that you can make me a co-host so that I can do a small presentation and show what kind of study that I did?
Yes, sir, you have first
Yeah, I got it. Access. Thank you. All right. Okay, I hope you can see the screen now. And yeah, so okay, so as Anthony mentioned, so there's a huge burden of stroke, approximately 2.7 million deaths worldwide. The main issue with stroke is now with the advancement of our therapeutics, we see a lot of survivors. And with the aging populations, we see the incidence of stroke increasing. So the disease burden is increasing by every day. And now we recently did a study and it shows that stroke is among the top 3 non-communicable diseases in the disease burden worldwide. Now, reduction of balance, impairment of balance in stroke leads to falls, and it's one of the commonest reasons for stroke-related morbidity and mortality. So there are different balanced rehabilitation regimes, specifically in like most developed countries. We can use things like aquatic therapy, this virtual reality augmentation, these kind of things. But these are very expensive, and we don't have access to these kind of things in developing countries, specifically Sri Lanka. So as Hansini mentioned, wobble board is like a very basic tool that we can use. It's an unbalanced, it has an unbalanced surface. And before we carried out our study, there was some evidence, some research that showing that wobble boards were used for enhancing the balance in athletes, managing pain syndromes like in the ankle pain syndromes, or rehabilitating ligament injuries, like specifically when you have a ankle twist or something like that. Now, we didn't have any evidence on whether we can use wobble boards for stroke, except for one little study that was done in an African country where they have only compared like 8 patients. And they initially gave us an indication that this is safe for stroke patients, and maybe it will have a benefit, but it was not very statistically significant. There was no blinding, no clinical trial. So based on this, one of our fantastic physiotherapy students whom I co-supervised with Prof. Anthony, Yasith, he came up with this brilliant idea to conduct a clinical trial and see whether it has an effect, like whether the wobble boards have a better efficacy, as well as is it safe to use after stroke, after like hemiplegia, middle cerebral artery territorial stroke. And the comparing, like the control group was the conventional physiotherapy. So we wanted to check if our if incorporating wobble board exercises provides an equal level of efficacy or even better than that. And at the same time, we want to check the safety. So the methods, again, I'm going to introduce some new terms. You might have heard, you might not, but don't worry about it. The main thing is it was a randomized trial. So randomized means we allocate the patients who come to our clinics randomly to either treatment group, which is the wobble board therapy, or the control group, which is the conventional physiotherapy. And observer blinded means everyone who is assessing the patients are blinded to the therapy that they undergo. For example, say a doctor is or a physiotherapist is checking the work balance score or the 4-step test score, something like that. But the person who is assessing does not know whether the patient underwent either conventional therapy, conventional physiotherapy, or the wobble board therapy. So a superiority trial means we hypothesize that by combining wobble therapy, we'll have a better balance after our trial. So that's what we call a superiority trial. Right. Setting, we did it at Stroke Rehabilitation Unit, National Hospital, Sri Lanka. And participants inclusion criteria, it's ambulatory patients. That means the patients, despite having a stroke, can walk. And ischemic stroke of middle cerebral artery, if you are first year, you might not know. So it's a particular part of the brain which controls most of your motor functions. And patients having a lot of strokes, like multiple strokes or anything that affects with movement, like the test that we are doing, were excluded. So I'm not going to go through this. This shows how we can use the work balance score. So ideally, this is a score which measures their balance. So we are asking a lot of questions, and so we are asking the patient to do a lot of actions, and we give a score. So in a work balance score, if the score is better, say the score is high, the patient's balance is high. But on the other hand, in 4-step test, as Hans-Jenny mentioned, you are asking patient to just jump on these things in a particular sequence, and you check the time that was required for this. So if the time requirement is less, the functional balance is better. So if the balance is better, just to reiterate, work balance score will be higher, and the 4-step test, the time will be lower. All right. So sample size, we did a calculation, don't worry about this. And then we ultimately randomize the patient. So don't worry much about how we did this. So one thing that you can incorporate in your research is when you do your community stream research, you can randomize patients. So we'll use different methods, the manual methods. You can just, toss a coin or something like that, or you can even use computers. It's pretty easy now. If you just go to ChatGPT and ask, can you help me with randomization? They will give us a sequence. Pretty easy now. Okay. And then don't worry much about the block sizes. What is this block randomization? It's a different type of randomization. I'm happy to discuss this if you are curious. And 1-to-1 allocation ratio is like half of the patients go into conventional physiotherapy, half of the patients go into wobble wave therapy. And blinding, as I mentioned, the physiotherapists who were assessing the work balance score and the 4-step square test were blinded. They didn't know what the patient underwent, whether it was conventional physiotherapy or the wobble board test. All right, this is a picture of wobble board therapy, the interventions that we did. Actually, what Hasita did, I was not involved in the intervention. So we ensured that the patients were pretty stable, and we kept 2 bystanders on either sides, and then the patient was asked to balance on this. It's not much complicated thing, but there was a sequence of steps that they had to follow. Like, you first sit down and try to do this, and once you're comfortable and confident, you stand up on this, things like that. All right. Now, this is kind of a tricky setup. Now, the intervention group we let them use the wobble board for 30 minutes, followed by conventional physiotherapy for 20 minutes. For example, conventional physiotherapy means we ask them to climb up and down a staircase, or maybe try to do a hand wheeling or different types of things. That was the standard protocol at that time at National Hospital. But for the control group, we asked them to do conventional physiotherapy for 30 minutes, followed by again conventional physiotherapy for 20 minutes. So altogether, it's a 50-minute protocol. And we did this weekly for 6 weeks. So I invite you to think why we combine this with conventional physiotherapy without just giving wobble board exercises for the intervention group. Why did we have to combine it with conventional physiotherapy for at least 20 minutes? Can discuss it during the discussion. All right. So statistical analysis, I'm pretty sure you haven't gone through these type of tests. Now, some of you might have done the community stream. So still in the community stream research, you might not know what is a MANOVA. So don't worry much about it again. So what I wanted to do was combine the score of work balance test and the four square step test and see if there's a improvement from the baseline after these therapy in these two groups. Okay, so this is how so in a randomized controlled clinical trial, you have to show how many patients were eligible and how we randomized and how many patients underwent the treatment and how many patients underwent the conventional therapy, the control, and how many dropped out during the trial. So we just provide something like this in a paper. And this is an analysis of the baseline characteristics of these two groups, in the intervention group and control group, because we want to show after random allocation, like before the intervention, the scores for four square step test and the work balance test in the intervention and control groups were almost similar. So if you look at these values, they look almost similar and they are not statistically significant. So if the p-value is more than 0.05, we call it not significant. All right. Now we did the analysis, and as you see here, in the interventional group, if you compare with the control group, both have improved four square step test and the work balance score when you compare before and after. So now using this method, we can't say exactly whether our wobble board analysis, wobble board therapy helped in gaining balance. So to compare that, again, if you look here, you'll see in the intervention group, this is the work balance score, and you can see it has improved in the intervention group and the control group. But you see there's a slight difference between the intervention and control group. The intervention group has improved a lot compared to the control group. Similarly, the four square step test, you can see intervention group has improved the time that is required for doing that sequence compared to control group. So there's a subtle difference, but you have to statistically prove this. So for that, we did this analysis called MANOVA. You might have heard of something called ANOVA if you have gone through the community stream research stream. So ANOVA is something that we use to analyze differences between multiple groups. Now, I don't want you to learn about MANOVA, but we can discuss at the end if there are easier methods that we could have used, like the test that you might have heard about, chi-square test, t-test, correlations, ANOVA, those kind of basic tests. So I would like you to think about the basic tests that we could do, and maybe we can discuss about those things during the discussion. So however, when I did this analysis, you can see there was a statistically significant difference, and the improvement was much significant in much more in the intervention group. That is, when you use the wobble board therapy compared to controls, and there were no injuries at all. So in conclusion, we say the wobble board therapy are safe and effective in restoring the functional balance in patients with stroke. And I should thank again Yasith, who did this massive study during the short period that he was allocated to do during the research stream, and he is fantastic. And he did his masters in the UK, and he recently told me that he got a first class for his research component. So he's doing fantastic, and I just wanted to thank him, and also Prof. Anthony, who helped in this. And I would really like to hear your thoughts about this, and you can discuss.
Right. Thank you, Dr. Yasith, for that overview on the article. So the floor is now open for a question and answer session where we'll be discussing the article. Before that, so I'd like to ask, so all researchers, right, are formulated around a research question, right? Fundamentally, the practice of evidence-based medicine is we have a hypothesis or a question that we would like to either a hypothesis that we would like to prove or disprove, or a question that we would like to answer. So I'd like to ask the audience first. You guys have been provided with the article beforehand for you to appraise it. I'd like to ask the audience, what do you guys think is the research question that is that led to the formulation of this topic? Can we have some answers? You could either unmute and speak, or you can just send it in the chat.
I think it's a great question. Don't worry about getting your answers wrong. We are just trying to improve ourselves by discussing these things. So just come with some answers, so we can refine your answer, and that's the only way to improve yourself. So no one is going to judge you. This is not an exam, so just come up with some ideas.
So hi, I'm Niket from the 2020 batch. So if I'm just to clarify, so the point we're discussing is whether the question, like what we think about the research question, right, like that was tested in this study.
No. Yeah. So what do you think is the research question posed in this study? Yes.
So from what from my early reading of this, after it was provided, the sort of question that I got was, is the use of wobble boards in a Sri Lankan setting a practical way to, or an effective way to, regain balance for people with stroke? Is the sort of, very simplified question that I understood.
Is that right, sir?
Yeah, that's a great answer. So I saw a few answers popping up in the chat as well. So I think Kubishek said 2 wobble boards improve stroke rehabilitation. Yeah, that's the perfect question. So we wanted to see whether by introducing wobble board, whether we can improve the balance after stroke rehabilitation, like during stroke rehabilitation. And another question, that's the primary outcome, but there was another question, whether it's safe as well, as Niket said, whether it's applicable in a setting like in Sri Lanka. That I think you gave an excellent answer for that.
All right. So before we...
to add one thing, so is it to say it is superior than conventional physiotherapy, or to say that it basically works?
Yeah, okay. That's another great question. When we do clinical trials, for example, when we develop a new drug and then when we have to test it, there are 2 approaches that we can say. Okay, so imagine for fever, you have paracetamol. Someone develops something like paracetamol. So we can either say our drug is as effective as paracetamol. that is called a non-inferiority trial. So that we are saying my drug is not inferior to paracetamol, so we should get the same recognition as that. So that is one thing. The other approach is saying, okay, my drug is much better than paracetamol. So that's called a superiority trial. So here, if you look at the objectives, we said this, in the methods, we said this is a superior trial. So before starting a trial, we in our project proposal that we are hypothesizing that wobble board therapy is beneficial, is better than the conventional physiotherapy. But why do you think we had to give a little bit of conventional physiotherapy as well without just going and doing wobble board therapy only? What do you think? Anyone?
I thought that because there's an ethical point of view there, because you'd be withholding the conventional treatment and we don't know if the wobble board works, so you'd be not giving them what they could have gotten. So.
Exactly. So one is, of course, ethical. We don't know whether our therapy works, so it's always better to have the conventional therapy combined with this. The other approach, the other problem was we didn't have evidence whether wobble boards work on stroke patients at all, apart from only one study that was also a bit sketchy. So if we had enough data from a small preliminary study, or say what we call a pilot test or something like that, if we had enough evidence, then we can say, okay, we are only going for wobble board therapy. But since we didn't have evidence, we had to always combine it with the conventional therapy. So ethical issues and having no evidence at all. There's another question. May I read it?
Yes, sir. Yeah. Go ahead.
It says, is it because of ethical aspect of beneficence and non-beneficence that we gave to? Of course, the question asks if it's because of ethical aspects that we gave 20-minute normal physiotherapy for both groups, as we were unsure of the effectiveness of the wobble board exercises. Perfect answer. Yeah, thank you very much. Yeah, you gave me the answer.
Sir, another small question. Now, from the study, we mainly included wobble board exercises with normal physiotherapy exercises, right? So, sir, can we say that the study was mainly not like looking isolatedly at wobble board exercises, but actually kind of including wobble board exercises as part of the exercise regime, kind of like that?
Correct. Excellent suggestion. So if you look at the conclusions, we have written it in a way that wobble board therapy combined with conventional physiotherapy is superior to conventional physiotherapy alone. So exactly as you said, we can't say it's just because of wobble board therapy. There may be an interaction effect between, like, patients who are doing wobble board therapy are better at doing other exercises. You'll never know. So we can't exactly say it's only wobble board. It's always wobble board combined with the conventional therapy is better than the conventional therapy alone. Excellent. I really like these questions.
Sir, going on the same lines, is there a place for a future study to be planned using like more involvement of the wobble board or isolated wobble board therapy? Do you think like it will be effective, or?
What do you think? What do you think based on these results?
I personally think, sir, like combination is better, because when we think generally of the balance component, like what I feel is like, because so many exercises, different types are being involved, the different aspects of balance can be improved. So it's always better to go with the combination. But I'm not very sure about the scientific background. So any input on that?
I 100% agree with you, because this may only improve one aspect of balance, and this evidence is not good enough to say that we should stop all the conventional physiotherapy. We are only looking using two balance scores. There are so many other balance scores, and this functional balance is only one component of it. So I would say it's very naive to think that wobble board therapy alone can do such a thing. So I don't think, going for a different clinical trial with wobble board alone, I don't think that would be beneficial. I completely agree with Ronnie though.
All right. Then let's move on to the next segment, which is the research methods. So research methods is one of the most important things in a research that we have to analyze, especially because it affects the reliability and the validity of the results that we get from the research as well. So research methods include both the inclusion of patients, exclusion of patients, the allocation of patients, and so on. So anyone who's got any questions regarding the study methods?
So regarding the combination of wobble board and conventional, the time duration, I think it was 50 minutes in total for the control group, totally conventional physiotherapy, right?
Yeah.
And isn't that the problem? Because they have got prolonged time, they have got a larger duration with longer duration of conventional physiotherapy, whereas the other group hasn't got that amount of conventional physiotherapy. Isn't that a problem?
Yeah, that's a great question. So whenever we are combining another therapy, we could have taken two approaches. One, we give conventional physiotherapy for both arms. Say both we give 50 minutes, and we give additional 20 minutes of wobble board therapy for the intervention group, but the controls don't do anything. Now, if you check the amount of time, like the duration of time that we give physiotherapy, like in total, in that case, our intervention group will have additional 20 minutes of some sort of a physiotherapy. So someone could come and argue, okay, these patients are exercising more, so it's obvious that they'll have better balance. So actually, when we did these things, we actually measured what kind of things that patients do at home. Say, we train this, and they go home and they do all sorts of other, say, aquatic therapies or any acrobats. So if they did those kind of things, again, that's kind of a factor that affects our study. So we had to make sure both groups get the same amount of physiotherapy, totally. But the type of physiotherapy that you are getting could vary. So since I think to introduce wobble board, the only method that we can do is give some wobble board therapy and reduce the amount of conventional physiotherapy that we are giving. So there could be, like, if the ethics allow, if it looks all right for patients, then we can have different approaches. Like one group gets only wobble board, one group gets only conventional, the other group gets half wobble board or conventional. So there are different study designs like that. But again, we had ethical issues. We had we didn't have enough evidence before introducing this. So that's why we said total duration of 50 minutes. Both groups are getting the same duration, but one group is getting wobble board plus conventional. I think that was the best approach that we could take. But if you have a better idea, please, I'm happy to discuss. What do you think, Angelica?
I know, so that was the main question that I got. I think that's only fair enough what you said, yeah.
Yeah. Okay. I have a question from Harindu. If I may read it as well.
Yes, sir, go ahead.
Okay. So for exclusion criteria, why were patients with multiple strokes excluded, but those with chronic strokes were included? Is it to automatically exclude those who are not ambulatory, as those with multiple strokes are likely to be? My question was considering that isn't chronic stroke also likely to have risk of reduced ability to heal just like multiple strokes? Excellent question. Excellent question, Harindu. So again, a bit of a complicated situation here. Now, when you have multiple strokes, usual multiple strokes can occur in different parts of the brain. And it has also shown that when you have multiple strokes, the ischemic injury that the patient gets will be sometimes out of proportionate to the actual injury. So we cannot exactly say imagine a patient is having a stroke in one part of the brain and having another stroke in another part of the brain. So that those patients are usually ambulatory, and it's not confined to one territory. So we thought it's better to exclude those patients, even though they could walk and talk. As you said, we didn't have an exact reason why we excluded multiple stroke patients. Again, an excellent suggestion, but we thought it's better to have a single middle cerebral artery territory infarct. And also we wanted to assess the duration between the stroke and when the physiotherapy was started, because it was also found to be a factor that affects the rehabilitation in other papers. So we were to find when the exact stroke happened and when we started physiotherapy and whether it also has an effect. And when we did our analysis, we included that as well as we call it a covariate, like another factor that could affect this. So it's mainly for statistical analysis purposes and to find the exact duration. Great
and was
question.
there a difference? Was there
actually,
if so, was it statistically?
Yeah. It's a great question. So if you look at the baseline characteristic, there's a table that I showed. In the baseline characteristics, the durations between stroke and the intervention or control, whatever, was comparable in both groups. Like there was no statistical significance between those two. So we didn't worry much about it. Yeah, I don't think it had an effect at all. But other studies, previous researchers have shown that there's a difference. Have I shown this here?
It has not been mentioned, I think.
It has not been shown. Yeah, great. Sorry, my mistake. I think maybe I wrote it in supplements, but I'm sorry, I might have forgotten. But that's a great question. Okay, there's another question. In your study, both groups had similar baseline characteristics. And if by chance, one factor like gender was different in both groups, one group was predominantly male, other group was predominantly female, would this have been a confounding factor? And if so, can it be corrected in the analysis phase? Wow, excellent questions. Yeah. Yes, we can do. So, I mean, it's not ideal to have those kind of things because when we are randomizing, we should ideally see similar baseline characteristics. Most of the clinical trials, if you do this properly, we get similar characteristics, but very rarely, we might get these kind of things like one group has more males compared to the other group. So when you do statistics in like a little bit of advanced stuff, not the simple tedious chi-square, ANOVA, you can control for these confounding factors. So there are different statistical methods that you can control for it. So the computer thinks, okay, now there's a difference and I'm going to adjust the effect of this, say, gender on this analysis. So one approach is that. The other approach is doing something called subgroup analysis. Subgroup analysis, once we get the full result, we do a subsequent analysis only on male patients and only on female patients and show if there's a difference. So either by controlling for confounders or doing a subgroup analysis, we can correct it during the analysis phase, but it's not ideal. Excellent questions.
So another thing about the exclusion criteria. So I was just wondering now that these non-ambulatory patients were excluded, perhaps not in the study setting, because I suppose that might not have worked.
Yeah.
In a practical setting, would this sort of wobble board intervention not benefit them more than the ambulatory patients because they don't have any sort of movement at all? So I was wondering if there was a place for that.
Yeah, excellent ideas. Actually, we were thinking about this, including non-ambulatory patients and doing maybe wobble board exercises while the patient is seated. So how we started this was we asked the patients to just sit down and keep the wobble board just under their feet and try to rotate it or tilt it to the right, tilt it to the left. But then we thought if we have, then we don't have a a score to assess, like a readout. We don't have a readout, so we can't ask the non-ambulatory patients to do force grasp step test or Berg balance test. I'm pretty sure there is a method to analyze these things, but my physiotherapy knowledge is very poor, so we thought it's easier for us if we have a solid, like standard readout like this, like a score which has been validated by many other researchers and has been used pretty frequently. And I completely agree with Niket. Maybe they might have a better outcome. So if we can extend this research, it will be fantastic. Or just try this among patients and see how they respond. That will be fantastic.
So I have a question regarding the wobble board itself. So just searching when we got this paper, I just searched what a wobble board is and so many pictures. So one of my questions was, what kind of wobble board did you use and what is that perfect wobble board so that even patients can make this, go to a carpenter, make it, and if you give the specifications, you may be able to do it at home, right? So is there effect with the wobble board on the study?
Amazing question. So in most of these clinical trials, we have to explain even the tiniest detail that we do, like even the tiniest methods, exactly as you mentioned, what are the dimensions of the wobble board, what's the height of the wobble board, and what's the first step that you did in this analysis. These kind of things, we have to write these things in our protocols, and also we have to publish these things in our paper. So if you go through the paper, there is a link for supplementary material or supplementary method. So supplementary means it's not usually published in the journal, but if you are interested, if you want to do something like what you suggested, you can go into these methods and find out the exact dimensions of this wobble board. So I can't tell you on top of my mind what's the dimensions, but if you go to the supplementary methods, we have described the size, the height, and the diameters and everything about the wobble board specifications, and also the exact test, like exact exercises that we did, like for 10 seconds do this kind of an exercise, and then for another 10 seconds do this kind of an exercise. So everything should be included in a clinical trial, in at least in the supplementary method. Excellent questions. I really like this discussion. Oh yeah, we have another question from Nuha. As per the article, Berg balance score and force step square test had been recommended and validated for elderly populations with impaired balance due to strokes. What about its validation for the younger population used in the study? Would that not change your interpretation of the results? That's a great question. I honestly don't know the answer for this. Yeah, I cannot remember exactly, like as Nuha says, this is only validated for elderly populations. I honestly don't know the age cutoff that this was validated for, and I do not know if there's any evidence to say that this is not valid for younger population. Yeah, I honestly cannot answer that question, but that's an excellent question. We would have actually thought whether this is valid for young patients as well, and if there's any discrepancy that is published saying if it's not valid for younger patients, obviously we can't use it. Great question. I honestly don't have an answer.
And sir, while we're on the topic of verbal score, is it equally validated for patients with both acute and chronic stroke? Or only for acute or only for chronic?
As I remember, Berg balance score is it's validated, like it's a very valid tool for not only for strokes, for any kind of balance impairment, and it can be even used for like patients with like subtle balance impairments. So I can't remember if it has been validated for acute and chronic, but it we actually cannot use acute stroke patients, like immediately acute stroke patients, on these kind of physiotherapy kind of clinical trials without having proper what do you call evidence. I mean, we can. It's difficult when a student is running these. I mean, we don't have enough time to get all the registrations and ethics. So that's why, because of the feasibility purposes, we selected chronic stroke patients. So I'm not sure if this has not been validated for acute stroke patients, but to my understanding, this is a tool that's valid for any kind of balance impairment. But again, nice questions.
Correct.
So speaking of acute and chronic patients, I'm just curious whether the efficacy of the intervention has been subanalyzed separately for acute and chronic patients. Is there any difference between or a significant difference between the two subgroups?
Yeah. Again, great questions. I think this is kind of a similar question that one of the previous students asked whether it differs from when we start our physiotherapy regime. So based on the previous studies, it shows that if we start into like any sort of physiotherapy soon after the stroke, like in the acute, even in the acute phase, it gives better outcomes than waiting for a few weeks to start our physiotherapy. So I presume that if you use this in acute kind of patients, it would be much better, might have given better results. So I do not have data on that. One reason was the sample size was a little bit limited. So it's very difficult to do like subgroup analysis based on like acute, chronic, male, female, old versus young. It's very difficult because when we calculate the sample size, we calculate it just to assess one effect, whether the outcome is better or worse in the total population. But as you very correctly mentioned, if you can have a better sample, like a bigger sample, then we can do all the subgroup analysis like acute, chronic, male, female. Those are all fantastic ideas.
If anyone's got any questions.
So I think one participant has dropped out from the control group. Wasn't that issue in analysis because there's one less participant in one group?
Yeah. Oh, I'm so glad you found these things out. Excellent. So yeah, one participant had to drop out because I think that patient had to change the house, and then the patient couldn't come to our clinic. Yes, that has an effect on our analysis. But what we think is, whenever we plan a trial like this, we think, okay, maybe 5% of the patients will drop out, or maybe 10% of the patients will drop out. So we recruit more more in such a case. So initially, say if we calculate a sample size of 100 and to have this 5% dropout rate, I would always go for 105 patients. So it's all right for 1 or 2 patients to just drop out, and that is expected. And just one dropout is actually, it's pretty good. In clinical trials, you will see a lot of patients getting dropped out in both groups. So but it's a great question. So we always have to plan and calculate the sample size and add maybe like 5% extra or 10% extra in case like that. Great. Okay, that's a question. I'm curious to know more about the basis of sample size you have used in this research. Excellent. So we got the most criticism of our study during our ethical review, and since whether this sample size is adequate. Always when you submit your research for your ethical reviews, you will come across this. Now, I think going into details about how to analyze the sample size, I think it's a little bit beyond, because it might take a lot of time, maybe like 1 hour, to show you how to calculate a sample size for a randomized trial, how to calculate sample size for, say, a descriptive study to assess the prevalence, or a case control study. But I'm happy to share a small presentation, including maybe like 3 equations where you can use them for your study. So usually what you're doing is either a cross-sectional study to assess the prevalence, or case control study, or maybe very rarely you might do a randomized control trial. So I can share the equations that we usually use, and maybe with an example, if maybe I can email one of the organizers, and if they can share it with everyone, I think.
Yes.
Is that possible as well?
Yes, sir, that's possible. Yeah.
Okay, go.
Do we have any more questions regarding the study methods?
Sir, just a small question. Now, when we engage in our research studies, like many times we just told because our study methods are not perfect, and we, when planning, we get some things wrong. So, like from an advanced person with good experience, like what is your input regarding this? Like, do we have to get all the things correct when we are planning a research, or is it okay to just have a rough plan and then while going on with the research process to change and adjust? Or like, what is the best method according to your experience?
Yeah, this is the trickiest part of any study. So, I mean, even when I write a proposal and I submit, I get comments saying, okay, these methods are not appropriate, you should improve. I mean, it's a continuous learning process, and you should not get disheartened by the comments that we give from ethics review committee or something like that. One way to improve methods is read a lot of other studies. So when one of the students who took on this project, I told him to find all the literature and see how others have done it, and go through their limitations and see, in the limitations they might say, okay, it would have been better if this approach was taken, and this was a limitation which can be improved in further study. So that is one thing. The second thing is it's better to discuss it with multiple people. It doesn't have to be only your supervisor. So even when I'm doing a research, like even say I am supervising a research, still I get a second opinion from someone else. I send it out and say, could you please go through this and tell me what you think about it, if I'm missing something. So talk to others, or say even seniors, even if you have a mentor, someone, or even a friend. Like I remember when we were doing this community research project, I picked up some mistakes in one of my friends, and they gave me really good suggestions on how to improve my. So I did something about temperature measurement. I can't remember whether it was electives or so. I did a research for electives as well as my community stream. When I wanted to use a temperature measuring technique. And when I said, okay, I'm going to ask these questions from the patient, one of my friends said, no, you shouldn't ask. You should give them a thermometer and let them check, and then you can give a score. So simple things like that. They are, I mean, if you talk to others, you can always improve. It's all right. This is a learning process, especially with clinical trials. So most of our student studies, that's completely fine. But with the clinical trials, the problem is we have to first register it in a clinical trial registry. And if we make the slightest change, we have to justify it in our research. And the reviewers will go through the initial project proposal and see what I have written and what you have done here. And if there are changes that we cannot explain, then they'll be like, no, we are not accepting your article. So yes, later on, yes, you have to be perfect, but in the beginning is completely fine. You can improve yourself. And once you do like 100 research, then you will see, okay, if you look back at your research, you have done some mistakes. That's correct. So if I look back at my research, now I see how bad I have written the introduction part. I have mixed up the functional, like I have not written it in a logical way. I haven't written the functional balance I haven't described what static balance, what is dynamic balance, and what is functional balance properly in my article. So it's all right to make mistakes. You will learn with time.
Thank you so much, sir.
So I have a question. Because you mentioned the ethical review and the things. So now when we were doing our research, of course, we were not allowed to get some vulnerable groups in this research for research purposes. So usually we have not experienced asking such finding a cohort like this. So can you give us your advice when we are dealing with these stroke patients or ethical problems that can arise because we have no experience?
Yeah, yes, Yuni. Yeah, again, a great question. So we also had the same issue when we applied for ethics. So these are vulnerable population. So what we had to say was, now these patients are being monitored by clinicians in the clinic, and there will be two or three senior physiotherapists always monitoring what we are doing. So it's not just the student going there and doing the test. So always there will be one or two senior physiotherapists, and there will be people like advisors and like a monitoring purpose. And then we have to say, if there's a fall happens, what we are going to do. So we had to write a huge paragraph on that. So we made sure that there will be bystanders and a doctor always available in case of a fall, and to do a risk assessment. That's why we initially check the ambulatory score. There's a score. So we are asking whether the patients can stand up and walk, like at least to a certain degree. That's kind of a risk assessment. So if you're using vulnerable populations, you have to take all these precautions, like a monitoring system, safety precautions, like what happens if a fall happens, and how do you prevent these things. And then we have to provide interim like reports saying, okay, in the initial 10 patients, we didn't have any falls, so we are continuing our research like this, things like that. It's a bit tricky as a student, but as you go on, I'm pretty sure you can do that. And this was done by a student, so it is difficult, but it's not impossible to get ethical clearance for a study like this.
Thank you, sir.
Michael.
All right, so let's move on to the next facet of research, which is the data analysis. So, sir, you have used a statistical method called MANOVA test. I personally, and I think most of the audience are not well acquainted with MANOVA test. And sir, you did mention that there were simpler tests that you could have used. So if you could sort of give a brief overview on what MANOVA is and what those other simple tests were.
All right. ask the question back from the audience. I honestly don't want you to know about MANOVA. It's like a little bit advanced. Now, imagine now you are testing the Berg score, Berg balance score. It's like a, say, I can't remember how many items were there. Say it's a score from 1 to 100. Now, imagine you want to assess whether the Berg balance score has improved after the intervention or the control therapy. In this, among these two groups, so what kind of statistical tests can be used? So first question, what is Berg balance score? Is it a continuous, like numerical kind of a measurement, or is it a categorical measurement? That's the first thing, first question. And the second question would be, if it's a categorical, what's the test that you would use? If it's a numerical, like a continuous variable, what kind of a test can you use to compare these two groups? And some statistician come up with an idea.
If it is a continuous variable, is it the paired sample t-test? And if it is a categorical variable, is a chi-square test.
Excellent. So you have the paired sample t-test and the chi-square. So since it's a Berg score is a continuous value, you can use the t-test. Now, what's the problem with using t-test in this group? Now, imagine you have a person who has the Berg score of 20 at the beginning, and at the end you have the score of 90 in the intervention group. And another patient, there's in the control group, has the Berg score of say 25 in the beginning, but after the conventional physiotherapy, the score is now again 90. So now, based on this, what do you think? What are the implications? Can we still do the paired t-test? And if you are doing a t-test, what sort of adjustments can we do? This is kind of a difficult question. You might have to think a little bit more, but I'm sure you can come up with an idea. Now again, I'll rephrase. Now there's a control group and the intervention group. Both patients after physiotherapy, after the intervention or control, their score is 90. But before starting that, one patient had 25, one patient had 20. So there's an improvement. Improvement is different. So how can you analyze this?
Just thinking like off the top of my head, when you take the final whatever into consideration, wouldn't you be looking at the difference? So if you're
exactly. Well done. So you can look at the difference. So you can subtract the value, the say 90 minus 25 from that. The other one you can say 90 minus 20, and you can get this value, and then simply compare these two. Simple. Then what kind of a test you would do? Is it t-test or chi-square? Comparing the difference in these two groups. Difference, is it a numerical or a categorical variable now? Numerical. So what kind of a test you would do?
T-test.
Yes, very nice. So you can do a simple t-test and look at the improvement only. Now the last, most difficult question. Why didn't I do that? Can you think? Now imagine there are two patients. Oh, maybe think like this. Okay, I'm giving a random example. I don't know how this is applicable. Now you have two patients with dengue in your hospital. One patient has a platelet count of 0. The other patient has a platelet count of, say, 95. And the next time you repeat the blood test, the first patient now has a platelet count of 20, an improvement of 20. And the other patient again has improvement of 20, but from 90 to 110. Who would you be most relieved with? Like, what's the most significant achievement in this? Is it from 0 to 20 or 90 to 110?
0 to 20.
0 to 20.
Yeah, obviously, so 0 to 20. Now, imagine you have two different patients who has a Berg score of 20 to begin with, and another one maybe 35 to begin with. Now, the improvement from 35 above, that improvement might be physiologically different from improvement from, say, 15 and above. Like, even though the difference is same, the improvement may reflect something that's really different. That's why we use statistical tests like MANOVA, where they actually not only look at the difference, they adjust everything to the baseline parameters and give an output. The other thing is, now there were two readouts, Berg score and the Forsker step test. Now in MANOVA, MANOVA is a multivariate analysis of variant. Multivariate means we can combine everything together. So we don't have to do two t-tests for Berg scale and the Forsker step test. We can combine those two together and look at the improvement. So that's the basic idea of MANOVA. So we looked at the improvement, just not the difference. And second thing is we combined all the variables in our analysis in like one statistical model. You can, learning statistics, if you're interested, is not difficult. There are many books. I can send you some resources as well that you can use when you're using SPSS. So I learned most of my statistics by myself, and it's not that hard. You can just read a book or just ask ChatGPT how to do this and do it. ChatGPT is really, really good in terms of like statistics, and if you want to code or those kind of things.
Thank you, sir. So finally, sir, we would like to know, like, all, if not most, researchers and studies have some type of limitation to them, right? So it's best that we hear, I think the person who was there with the research from the very beginning, including the literature review, formulation of study methods and so on, I think that person is the best to sort of talk about the limitations of his own study. So since you're a co-author of this study, sir, what do you think are the limitations that are there in this study, and what are, like, briefly, what could you have done about it?
Yeah, nice. So I think most of the audience came up with the limitations we had. One thing, we didn't do subgroup analysis based on age, gender, or the duration from the stroke, whether it's acute or chronic. So I think those are the main limitations, and that all came because of our limited sample size. I'd say that's the main thing. And the other thing is, we did it in a setting where we don't have much resources, so we couldn't compare our intervention with the gold standard interventions that's there in the world. For example, they all are using like aquatic therapy, augmented reality, virtual reality, those kind of things. So, like, now they are becoming the gold standards for physiotherapy. So we only had a limited thing. So we can only say wobble board exercises is combined with conventional physiotherapy is better than just giving conventional physiotherapy in a Sri Lankan kind of a basic resource limited setting. So we can't say, okay, this is the best therapy compared to the rest of it. So I would say these two are the main limitations. If you know any other limitations, please let us know. Yeah, I think the time. Okay.
All right,
because of the time limitations. Yes, Nathan, go ahead. I think Nathan wanted to say something.
Yes. Yes, basically you have used two scales like the FSST and the BBS. Here in the both intervention and control groups, the p-value is less than 0.05. So how
Yes.
you like say intervention group has superior results, then what is the demarcation use for that?
Yeah, excellent, Adil. Yes. So what happened was, even if we give a conventional physiotherapy or wobble board therapy, both patient groups improve their balance, irrespective of what we do. So that's why the p-value is less than 0.05. But then when we combined all the analysis together, so initially we just do this kind of a preliminary analysis and say, okay, patients have improved. And then we do the statistical modeling, like what I said, MANOVA, where we combine both parameters together and we looked at how they improved. And if you see, there's another result called MANOVA result with a p-value less than 0.05. There we have showed that the conventional the wobble board therapy is better than conventional physiotherapy alone. So might be a little complicated because I have given both values, but it's all right. Don't worry about it. So both patient groups have improved, but if you look at the graphs also, you can see the level of improvement is slightly different. Like the level of improvement is much better in the physiotherapy, the wobble board group compared to conventional group. And then when we did the statistical modeling, we could show that it's significant in the wobble board group. I'm not sure if it's clear for you, Nadur.
Assume that if you got contradicting results in the both in the both states, then how would you come up with the conclusion? That means
contradictory results in the sense like there was no difference.
Didn't show like.
Sorry, Nadur. Contradictory results in the sense like the wobble board therapy was.
Yeah, in your research, the both results are aligned to the same direction. But if assume that if we got in one test we got positive, but in other test we didn't got like that result. So that means a contradicting one. That means it is not effective. So how you come to a final conclusion? Having
okay. So the first test is actually, I understand your question. That's very great. The first analysis was just to show whether the patients have improved, like overall, whether the patients have improved. So we expect everyone to improve over time. Even without physiotherapy, we expect them to improve. Like balance after stroke, because of the brain plasticity, they will invariably improve. But if you did this test and if it showed that this is better, that's all right. If it doesn't show that, no, say it's a contradictory result in the sense, now the Berg balance score, wobble board therapy actually reduce the functional balance score. If that's happening, actually we do like interim analysis. That means we don't wait until the research is over to do this. We do an analysis in between to see whether the trends are getting better or worse. If it's getting worse, we immediately stop the study. We inform the ethics review committee, something like this is happening, this is not the intended result, and that is not good for patients. So we are discontinuing our research. So that's how we tackle if we get a worse result. Did I answer your question, Nadur?
Yes, thank you.
Yeah. Asal, I think our time's running out and it's like 1 o'clock in the morning in Australia. There are two questions I just wanted to address. Whether I can suggest some easy to read textbooks to learn core concepts of statistics. Yes, I can send you a book to Asala, or at least a link to Asala. There's a beautiful book written by an Australian, and I got the opportunity to listen to one of her lectures when I was doing my PhD. I can share those information with you. Maybe if I can, maybe I have Niket's email address, so I can send it to Niket. And if you know the participants, please circulate it among them. Okay. So the question was if Berg balance score showed more significant improvement compared to post-graph status. Yeah, this kind of things can happen. And if that's the case, we simply say, okay, this is the result, and this could be the interpretation. This is good for one type. So then we can analyze and see whether what are the different functional components that are being assessed in Berg score and the post-cast step test. So those things happen. Those things happen all the time in clinical trials, and we say, okay, we see an improvement in this score, but we don't see an improvement in this score, and that could be a negative result. And nowadays, most of the journals, they are very open to these kind of things. I mean, I recently submitted a paper with a completely negative result, saying, okay, I don't see any difference between these two, and they accepted it and published it. So we have to be very transparent and say, this is what we see, and we just publish it.
All right. Thank you, sir. Thank you for valuable insights, and it was a great pleasure to have you with us and to hear your insights on the questions that were answered. We did pass our time limit a little bit, but I guess that's the nature when this discussion is as lively as it was. So thank you for the audience for proposing their questions and for engaging in a live discussion as well. So that brings us to the end of the question and answer session. I'd like to hand over the stage now to Abhilashi.
Okay, so that brings us to the end of the 6th edition of our Journal Club, orchestrated by the Medical Faculty Research Community. So as we draw the curtains on this session, I'd like to ask for any feedback from our research person, Dr. Yasith. If you have anything that would be valuable to us in our next upcoming Journal Club events, please share it.
I think this is a really good initiative, and I didn't have this kind of journal clubs when I was a student, and I wish I had. What you are doing is great, and I really like to see the questions that you ask, and you found like tiny things that I could have improved in this research, like say mistakes, and some of you have read the small text in the research and you came up with really good questions. So what you're doing is really great. Just keep it up. I actually honestly don't have much feedback for you to say, but when we are doing journal clubs here, what we usually do is like, as you did, one person helps in presentation, these kind of things, and others, rather than simply asking questions, I mean, asking questions is great, excellent. They come up with ideas. You could have done it like this, and why didn't you do this? Like, obviously you asked me, why did you do this kind of an analysis? Why didn't you do something like this? This is great. So come up with an ideas and say, you can improve. You could have improved it like this. Why didn't you take an approach like this? And you can also go into other data, like other publications, and say, okay, someone else has used an approach like this, and you could have used this. So things like this could improve the way that you read and way that you understand, especially if it's not your comfort zone, like say physiotherapy, these kind of things. I intentionally did it because you might not know everything about this, and it's nice so that you can go around and read and find out whether this is validated. Next time, find out whether this is validated in a younger population, and you can say, okay, what you did was wrong. So come up with things like that, just to improve yourself. But this was fantastic, excellent. I really enjoyed this session.
Thank you so much, sir, especially for your expertise and your willingness to join us amidst your busy schedule. I know it's really late night where you're right now. Your insights have helped us in deepening our understanding and improving the collective knowledge regarding this topic. So thank you so much, sir. And thank you, SLR, for your skillful moderation of the Q&A session. It has been pivotal in making this interaction dynamic and meaningful. And also to our diligent organizing team and the entire medical faculty research community, your commitment to the scholarly exchange has provided us a platform to explore ideas, challenge assumptions, and expand our horizons. And a sincere thanks to each participant who engaged with enthusiasm, driving the discussions to new heights through your questions and insights. Your presence has made today's event all the more meaningful. So thank you very much, everybody. Have a good night.
Thank you.